and working in a multidisciplinary environment with engineers has been really fruitful. So some of this work, not only in trying to increase the adoption of digital health in cardiology has been very important for us, but having the blessings from National Science Foundation and some of the grant support we've been able to bring over here. And there's another grant support, which is called as the Bridges in Digital Health, which actually tries to basically develop teamwork in how the digital health science should be propagated in the clinical environment. And this was an award we just won, and part of that will come also to us and allow us to train our junior faculty and trainees along with engineers. And then, of course, our interest in creating an in an academia and industry collaborative endeavor is going to be very pivotal in how we spearhead some of these changes that are going to be very important. But more critical for today's grand rounds, as I was asked to give a talk, and I was asked to define the learning objective, I decided to talk about the heart and how it works and the mechanics, and how we can use new technology to understand the mechanics and how it gets altered in different diseases. But a lot of you must be wondering why this title of that Waltz in my heart, and what that title has got to do. Is it glorifying something really from the heart, or is it just one such catchy phrase I decided to do? But there is actually a story behind it, and I want to share that story today. So the term waltz actually, we all know, comes from a German term that is to roll. And it's intriguing that if you imagine the amount of the work that heart does every day, it's a 300-gram average weight, and it pumps about 8,000 liters of blood every day, much more during activity and exercise without fatiguing. And it would be an amount of mechanical work that would be carrying 100 pounds, 1 mile high every day. Imagine that's the amount of work it does. How does it do it so efficiently? This is perhaps nature's most efficient design for propulsion. And what's got rolling to do with it, and what's the waltz behind it? So that's the mystery we are going to uncover today in my presentation. So the story starts back in India. So this is the busiest city, one of the busiest cities in the world, New Delhi. And one of the busiest centers, Delhi University, has a hospital called as GB Pant Hospital. So after doing my graduation and my post-graduation in cardiology at All India Institute of Medical Sciences, I took a junior faculty spot here. And since I was the youngest in the faculty, we would do a procedure called as balloon mitral valvuloplasty. And every day there would be close to about 20, 25 people lined up for this procedure. So it was like a mini workshop every day. So you go through one day, you are completely trained in that particular program. But since you're the junior most person, you get to do the one which is the work that is not attractive. And the work that was not attractive was to image this patient, because you have to make sure that, you know, after you have the balloon that goes up and it dilates the valve and it tries to open up, it's not creating any regurgitation or leakage, and there are no other complications. So I became the person who would start manning this big machine. This was the GE Wingmet machine in the cath lab. I would roll it to the patients and start imaging them. And I started fiddling around with the buttons, and suddenly I chanced upon one of the knobs there, and that created this picture. And this picture is a Doppler. Doppler measures the speed of movement, anything, of the blood or the muscle. So this is applied to the muscle wall, so the heart's wall, the left ventricle, and it got this squiggly waveform. And this we call this now as a tissue Doppler, and we use it. So this started attracting my attention and what this meant. And I started doing systematically collecting the observations. We subsequently, of course, published that before and after valvuloplasty as a marker of improvement in the ventricular function. This was subsequently published. So this is where my journey started. And I started asking questions. What is this? What do these squiggles mean? And We have the electrocardiogram, we know PQRST, the waveforms, we understand where they come from, which wall and what function and where it travels, we come from. Do we know as the ventricle how it's working? How do these waveforms get produced? And so what does the tissue Doppler does is it looks at the motion of the heart along the line of the ultrasound. And the left ventricle has a piston-like function. It moves up and down, up and down. And during this movement, it acquires the signal. And one of the most characteristic feature of the signals is very high time resolution. So you have a very high resolution of activities of the heart during the systole and the diastole you can capture. So you get essentially a wave in ejection when the heart is squeezing out, and then it's relaxing and recoiling back. You get a early diastolic filling wave, and then you get an atrial contraction wave. So you get very characteristic signatures. So that became the question that I started. How does it come from, and where do they come from, and how does the heart muscle move, and so on and so forth. So I started publishing. A dozen abstracts were published in one of these conferences. One of the mentors, subsequent my mentor, a faculty from Mayo Clinic was attending. So he just gave me an invitation to come to Mayo Clinic. So then I landed up in Mayo Clinic, and the first question I started asking was, how does the heart function? How does the left ventricle squeeze happen? So you have the left ventricle, and then you have all the myofibers and the myosheets and the muscle. But the tiniest and the final frontier of those myofibers is the myocyte, which has a twitch. Now that twitch is about 15%. So it changes in length about 15%. So how does this 15% change in the twitch of the muscle completely translate into a 60% volume reduction of the ventricle? Something must be amplified, and there must be something happening in the ventricle. Somehow that myocyte with a 15% twitch is able to bring a 60% change. And this is a ventricle, how it looks in an echocardiogram. This is the left ventricle at the top, and the atrium at the bottom, and you can see the mitral valve, which is moving in between. So how does that happen? So that became my first question. And so I started thinking about designing some animal studies and some translational studies, and started looking into the literature. Interestingly enough, if you look into the models of heart function, you will find that there are so many ways people have defined the heart. So when it started with the cath lab, with the introduction of the Swan-Ganz catheter, we started looking at the different parameters like output and stroke volume and so on and so forth. So it was a paradigm or measurements or identification of heart function using invasive pressure volume loops and curves. Subsequently, when the imaging came, we started recognizing that, okay, the heart squeezes. So with the heart squeezes, you could get the squeeze function, and terms like ejection fraction and so on and so forth came into existence. And suddenly in the 1990s, the whole shift happened into the neurohumeral, and everybody started talking about different type of neurohumeral compounds and ability to understand heart function and dysfunction using that. And finally, when the imaging became more and more prolific and available with all its nuances, we started really looking into the muscular function, the muscle pump, and different new terms were starting to come. And this was the time tissue Doppler and terms like strain, which is an engineering term of how something works, was coming into the literature in imaging. So the quest became, can we understand the muscle function, the myofiber function, and how really it changes from a 15% twitch to a 60% change in volumetric function? And then you further look into the physiology literature, it's very confusing that for describing the anatomy of the heart muscle in 2007, there are 7 or 8 different models. Imagine, there are 8 different perspectives of how the fibers are wrapping around in the ventricle. This was really confusing because I really couldn't go into one direction trying to understand, putting together the information that was coming in for understanding how the muscle was actually moving. So I said, I think we need to go ahead and do some basic work. in dissection. So I decided to write up ICOG protocol and submit it to the ICOG committee and so on and so forth. And immediately the email came back in Mayo Clinic. Okay, this is filed up, your information is filed up, 30 days. Now, I was coming for a year's research work. 30 days to get even started with animal work, that was something very problematic to me, in which I did not know what to do for 30 days. So I started becoming very creative. So you have here the world famous Mayo Clinic. I'm sitting in one of those rooms there, imagining what should I do for 30 days? Should I just keep on reading the literature, talk to people, or should I do some action? So I came up with some ideas, and I said that, okay, the animal committee is going to take some time to decide how to do my research, but they cannot stop me from getting some hearts. So I can get some hearts from somewhere. And as Fred says that Partho is very impatient, I became impatient, so I went to a butcher shop. And this is the year-old butcher shop in Rochester, Minnesota, and went to the owner and said that I want all kinds of hearts. Whatever animals that you have here, get me a heart. And the person really didn't understand. He was thinking that, what kind of dish am I going to make? But actually, I was not going to make a dish. I was going to package them and take them and use that to create my initial observation using my dissections. So I had deliveries from this butcher shop, which was like $30 of all kinds of hearts, goat heart, sheep heart, cow hearts, all kinds of heart, wrapped in a pizza delivery box. So I carried that. Now I needed a wet place. I didn't have a wet place, so I didn't have a lab to do this. So I had to be again creative about that. So I thought about an idea. Now this is a food, this is coming from a butcher shop. So I decided to use the break room. So the break room in the 6th floor on the Gonda building became my wet lab space. And every day after the people were gone, like 5 o'clock or 5:30, I would go into the break room and do my dissections there. I collected some utensils from people, and I would sit on the table and do my dissections. And the janitor would come around about 7 o'clock. So I would be done. So the next day it would be all clean. So it would be a perfect timing. So 5:30 to 7. So I started doing like all kinds of dissection. Now, after doing a series of dissections, I said that now I need to take this to a next level. So I invited then the then pathology professor, Bill Edwards, very famous for his work that did the correlation between the echocardiography cross sections and how it looks in the echocardiography images. So they had done some foundational work. So I said, Bill, I'm seeing something interesting. Would you be interested to come and help me out? And he decided to come and help me. So we sat down together, and I think that attracted some attention that we were doing something serious. But this break room became really synonymous with my work. And these are some of those images. And you can see here, I have timestamps, 5:35 p.m., 5:45. After the work was done and everybody was gone, when the break room was free, we would sit down and do this dissection. And this is a pig heart. Now, there was an interesting story to this. Now, the pig hearts would all come, these were all frozen. So they were all frozen, so I have to thaw them out. So how do you thaw them out? So I started using the microwave. So after you use the microwave, it would get half baked and half cooked. And it was actually very easier to dissect because the muscle fibers and the strands would become very coagulated, and you will be able to really see the strands very well. So when we started doing the dissection, this is the right ventricle and this is the left ventricle. This is the interventricular septum. You can see the strands in the ventricle. You really don't see any unique configuration. It's all spiraling. It's like all wounding around, round and round. So what is this? So just a very strong syncytium, like continuous network of muscle fiber. This is going round and round. But there was a directional change in the orientation of this network going inside to outside, from the endocardium inside to the outside to the epicardium. And I started seeing that subsequently in other of my work also. I got pieces of rat heart. We sliced them and put them under confocal microscope. You can see that the myocyte fibers, the inward tilt towards the inside, and then outward tilt towards the outside. And throughout the myocardium, you will see these muscle fibers and the muscle fiber sheets separated by spaces. And you can see here actually some of those spaces, even in a blunt dissection, if you'll see, you can see those spaces. So what would happen was the spaces and the way the fibers were arranged created a little bit of change in the directionality from the inside to the outside. And then subsequently, when we started doing the experiments in the animal, the pig's heart, if you put a high resolution transducer, you see this directionality of the reflected signals. These are called as speckles or ultrasound speckles. They kind of have some relationship to how the myofibers are organized. In fact, the movement of the inside to the outside, you can see the change in the fiber orientation and direction in a beating heart. This is an epicardial probe showing that same arrangement. So this became a very important observation that there was some shifting directions from inside to the outside. And we needed a term to come up with the spiraling orientation. So finally, we decided to give this a nomenclature that would be more commonly utilized. And we called it this as a helix. So on the surface of the epicardium, you have a left-handed helix, and you then see a continuous change of the geometry to a right-handed helix into the endocardium. So I started writing these papers and this initial observation and submitting them to journals. Rejection after rejection. I remember the first article was rejected 8 places. No place would accept it. Now, at the same time, it was very interesting that a group of people, surgeons from UCLA, along with a huge team from NIH, was organizing themselves into understanding the myocardial fiber geometry. So we didn't stop there. We said that there may be some relationship of this arrangement to the function. So we started becoming more creative. Let's look into the fiber direction and the motion using crystals, ultrasound crystals implanted into the heart. And these crystals speak to each other so you can understand how the muscle fibers are moving. And then deciphering the signals and trying to see its relationship to what we record on ultrasound examination. So that was the story. We got a success there. We got this paper accepted in Journal of Applied Physiology, where we showed that the inside endocardial surface and the epicardial surface had movements which were different from each other, and they had resemblance to what was seen on the ultrasound examinations. So that was our first success. But further, more paperwork would not make it to the top tier journals. And the reason was that there was several groups of people that had joined together into another theory that was getting propagated in NIH. And you can see here many important names, many big science, basic science researchers who had come together, and they put this strategic special report NIH paper and chaired by Jerry Buckberg, late Jerry Buckberg, he's no more. And I soon came to understand that there was a hypothesis that was prevailing in the community that was avoiding us from getting our work done, because our work was showing completely opposite of what was being suggested by the large forum of people, very distinguished group of people. So it really took us a lot of effort to get any of these papers published, and that's the reason it was getting rejected. But finally, somehow, after multiple rejections, the editors of Journal of American College of Cardiology, which is a top-tier journal, got attracted because they were seeing something similar, or at least there was some sympathy for the imaging insights that was more clinical in its orientation, and it was answering some of the unanswered questions. So this paper, which was camouflaged, you can see here, it was talking about timing of how the muscle is moving came into acceptance in Jack. And what it did was it simplified the action of the heart. And the action of the heart simplified from inside to the outside and presented here in animation showed that during the pre-ejection phase, there was, let's see if it works, yes. So pre-ejection phase, the subendocardial will contract, and because of its helical orientation, it will also rotate the heart. Then during the ejection, when the full sets of myocardium are ready to contract, it would eject out with a clockwise twist. So there was a rolling, unrolling, and during the ejection, you can imagine this helically wound fibers as they are ejecting out. There is a memory, a shape memory that is stored in during the active phase of ejection. Now that spring that is twisted now would uncoil back and create the forces that are required for sucking the blood in for the beginning of the diastole. So we started describing the echocardiographic anatomy and the mechanics and the rotating and the moving motion that are clinically observed using this model, basic science model. And I think that's why it got acceptance and it was published. Now, that's the time when the editors wrote this paper. And this paper was accepted this paper. This paper was also describing and the change. And that change was the beauty of this fiber orientation from inside to the outside with all the laminated networking and the spaces allowed the muscles to roll. So when the ejection happens, it's not just a twitch, but the twitch is able to roll the muscle just like you're rolling up a sheet of paper. And this rolling up actually was able to displace inward and amplify a 15% myocyte contraction to a more than 60% change in volumetric function, ejection fraction. So there's a beautiful design here from how a twitch starts. There is a cadence, an electrical activity, a mechanical activity from inside to the outside, the endocardium and the epicardium completely opposed to each other, yet completely synergistic during ejection, bringing this large volumetric change, and then this using the synergy to uncoil back. And this rhythm keeps on happening. And at that point, the editors wrote this editorial, and the title of the editorial was "Of That Waltz in My Heart." And I decided, that's the reason I decided to bring this title to my presentation today. So the endocardium and the epicardium, myocardium, they are very synergistic. Just like in a waltz, you have to be very coordinated because this discoordination is what causes dyssynchrony and heart failure. And that's what you synchronize using electrical therapies. This dyssynchrony is so critical for the function of the ventricle. It's so critical for the way the heart functions rhythmically, becoming an efficient organ, that understanding this waltz, this dance, this rotations, this twist that is so important is paramount importance for how we would define subsequently our diseases in clinical practice. And the biggest victory was when Jerry Bergberg himself, as a guest editor, accepted this paper, which was in 2006. I think this was a full skepticism converted into, and it was very fruitful to see the acceptance of the work. And this is one of my first five highest cited work on the basic configuration of function, structure and function of the ventricle, as we see in cardiac imaging and how we use that for clinical imaging. So where do we go from here? Well, there's another important aspect. After that came the technological revolution, we started seeing a big uptake of what is called as speckle tracking echocardiography. Now we have this ability to track the muscle in the heart. And this technology is currently available in our labs, is being used. We call this as speckle tracking. And the speckle tracking is basically tracking of the muscles from the inside to the outside, and the function and the estimation of the motion and different parameters of myocardial function that comes out from it. But the speckles have their basic genesis of how the myocardium is arranged. The way it is arranged creates the speckle arrangement, and that's what we track. Subsequently, in 2011, when this national recommendations guideline paper was published, this $30 picture from the butcher shop went into the national guidelines. So this was the biggest claim to my victory, in which the first month that I spent in Mayo Clinic had its fruition in a national guideline. Even now it is cited multiple times. So this was really amazing to see the picture find a place in the national guidelines. Now, why is this arrangement so critical? This arrangement subsequently has now been confirmed using high resolution techniques. And this is a MRI where you can see the fiber geometry extracted from the motion of the subendocardium to the epicardium has the same helical configuration. Not only that, simple diseases like hypertrophic cardiomyopathy, where one of the commonest diseases in the population is very highly prevalent, as common as a deviated nasal septum in prevalence. The muscle fiber hypertrophies with a spiral configuration. So there is a way diseases also express in clinical practice. So there is a relationship to the fiber geometry, not only the heart function, but also how diseases come in clinical practice. And this work subsequently from UCLA confirmed Hiroshi Ashikaga's group. Now, Dr. Ashikaga is in Johns Hopkins. They confirmed this sequence of mechanics that we had proposed. And incidentally, they called me to write the editorial. And I was very delighted to write an editorial. And I used the term heart has its reason. There are very foundational reasons why the heart has specific geometry and how it works. It's the efficiency and understanding that the most efficient design in the nature can really provide us insight in understanding how diseases express in clinical practice. And now the technology is really galloping. We have the ability to understand the strain and the fiber function in 3 dimensions. This is a 3-dimensional strain, and this can be extracted out and performed in clinical practice. One more question that I started asking immediately after this helical fiber orientation was really intriguing. And many times in the past, anatomists have used the term vortex cordis to describe the spiraling orientation. And I started asking the question, is there a resemblance of why is the fiber wounding? Is there a relationship to how the blood flow propagates inside the cavity? Now, what is a vortex? And you will encounter this. If you just rotate water in a beaker or in a cup, you just stir the coffee in the cup, you will create a vortex. And a vortex is a counter-directional flow of current. It has got a descending limb and ascending limb of how the water spirals down and climbs up. That's the anatomy of a vortex. Intriguingly, indeed, the fiber orientation had some relationship to how the blood flow could be moving in and out of the ventricle. So that started leading to another sets of hypotheses, and we needed something to show it. Now, to use it, we needed high resolution. So we started working on a technique called as particle imaging velocimetry. Now, these are small contrast bubbles. Now, contrasts are used in clinical practice, but here I have sent the contrast in the chamber in a very diluted fashion. Now, when the contrast bubbles are then tracked over time, you would be able to create the anatomy of how the blood flows in through the ventricle and comes out. And this work, where we created an experimental animal model, and we described the technology of tracking the blood flow in 2 dimensions, again, was on the cover page in JACC for its inception. And in fact, I created a intellectual property at Mayo Clinic that was subsequently licensed to Samsung, and that is currently being utilized. It's called as particle imaging velocimetry. But nevertheless, in high resolution, this is how the anatomy of the blood flow would look like. This is your electrocardiogram at the top. This is the atrium at the top. This is the ventricle. Somewhere here is the mitral valve, and somewhere here is the aortic valve. As the contrast bubble come and go, and if you track the way it is moving out, you create this path of motion. And when you see this path of motion during the cardiac cycle, you see this creation of a beautiful vortex inside the left ventricular cavity. Now, you see a very large vortex as the flow is coming in early diastole and then going up in late diastole into ejection. Now, one thing becomes very clear. The heart is not a pressure pump. Heart is not a squeezing pump. It looks like it continues to conserve the momentum of the blood flow. So this design of the ventricle is something that shows that never ever during the phase of cardiac cycle, there is hemodynamic stasis. The energy with which the blood comes into the ventricle is conserved and is presented out to ejection. So there is a beautiful flow topology that is happening continuously, but where there is conservation of energy from systole to diastole and diastole to systole, and the counterdirectional arrangement of the myofibers is actually helping that energy to be conserved. And this work was again on cover page of Nature Cardiovascular Medicine for a year. They in fact showed this, displayed this on the cover for a very long time. But the question started becoming very important. How do we translate all of these insights? These are very, very beautiful observation. What does it mean to a clinical cardiology? And there has to be some translational aspects to diseases. Could they be done in clinical practice? The answer is yes. Now, these are all possible. So you can actually track the contrast bubbles. You don't need even contrast. You can just track the blood cells from the Doppler, color flow Doppler. And this is the vortex now being isolated inside the left ventricle using color flow Doppler. Not just color flow Doppler, you can actually track the blood cells and create this beautiful streamlined motion. And all of these are FDA approved, available for clinical practice, and ready to use for prime time. The question is, how do we use it and where can we apply it? Technology is there. So physiology is there, technology is there. The question is, how do we apply it in clinical practice? Not only in the left ventricle, we subsequently showed that even in the atrium, the reason the atrium is there is because it is a good receptacle for the blood to come in, and the blood never becomes static. In fact, it becomes static, you start developing clots and you have stroke. The blood is always moving, even in the left atrium, but it's a good receptacle so that there would never ever stasis, even when the ventricle is generating a high pressure and the mitral valve is closing. The atrium is receiving and keeping the flow continuously, stirring it continuously, ready to go and go into diastole, and the filling continues. And there's a beautiful synchrony even from the atrium to the ventricle. Not only that, inside the right ventricle, if you try to look into the configuration of the right ventricle, a lot of people think about what is the right ventricle doing? Well, the right ventricle doesn't have any vortex. This vortex, which is present on the other side in the ventricle, actually allows the right ventricle to pump. So in fact, it's like a reservoir that is having an energy, and each time the pumping action is happening, what happens is on the interventricular septum, a pulse is created on the interventricular septum, and this pulse allows the right ventricle to eject out. In fact, using this particular theory, we looked into patients with left ventricular assist devices, and patients where the left ventricle assist devices are implanted, the right ventricle is unsupported and would fail. And we showed that by looking into this pulsatility of the interventricular septum, which is related to this vortex that is created in underneath it, can predict which right ventricle would fail after left ventricular assist device. And in fact, you can see here, Dr. Akabu was a resident at Mount Sinai when this work was done. And we were able to show this particular trajectory of how the design of the left ventricle supporting the right ventricle could be an important insight in predicting right ventricular failure in LVAD. So this theory also exists and can be utilized. But the problem is, the question is, how do we apply it? You know, when you start applying in the routine clinical practice, the mundane questions become the important bottlenecking factors. Financial issue, less reimbursement, budgets, workflows. How do we get all this data extracted in a short period of time? All this different observation, how do we make and translate it into an actionable information that can be used by a hospitalist or a clinical medicine person who really want to take care of a patient? So how do we bundle this all up into a package that can be used for clinical practice? And that's where I started looking into how could technology bundle the big data from echocardiography using innovation. And that's where we started positing that machine learning and automation may be perhaps extremely important for translation of these activities. And this was the work. In fact, this is my first ever holographic presentation. So the reason I used holographic presentation was because it was a very important presentation. Harvey Feigenbaum, father of echocardiography, named lectureship. And I wanted to present not only the work, but also the future. So I decided to use a technology in which I was able to provide an impactful presentation of the future. And there I was able to suggest that perhaps this is the direction of using machine learning and automated technologies would be one of the ways to look forward. And this work is available on the Google, and I'm very proud that it has received a lot of excitement worldwide. What we stand currently with is that we have recognized using technologies like spectral tracking echocardiography that you can characterize heart failure much better. Now, so-called heart failure with preserved ejection fraction, where the ejection fraction is preserved and the heart is failing and the patient is congested, ejection fraction is not able to capture the problem. But if you look into the muscle mechanics, you will see an impairment in muscle function in the longitudinal direction. And this is very well accepted right now. So if you use high resolution spectral tracking using a terminology called a strain, you can pick up much earlier at a subclinical phase and predict a patient who will go into heart failure with preserved ejection fraction. And the same is true with heart failure with reduced ejection fraction. If you start seeing all the compartments of the heart from inside to the outside starting to decline, you know that this patient is going to go into heart failure with systolic dysfunction. So that kind of paradigm is already there. We are using strain currently in clinical practice. I think we will need an effort to see how this can be adopted and utilized for clinical translation and ready utilization for subclinical disease detection. We are right now reactionary. We react to only detecting heart failure patient. We need to be proactive and be able to predict and be able to better manage those patients moving forward. And these technologies are available. In fact, Dr. Bhari and colleagues are already using strain in cardio-oncology to predict the changes in heart function using cardiotoxicology. But now was the opportunity for me to get young investigators and faculty excited. And we propose these classifications on integrating new technology of how the heart failure paradigm could be predicted, where you could look into the left atrial function, left ventricular function, right ventricular function, using automated tools to see the full continuum of evolution of heart failure from stage A, where there is only risk factors, to stage D. And suffice it to say that stage A, which is a change where patient is completely asymptomatic, only with risk factors, and there is no change in clinical heart function in form of ejection fraction, or even there is no hypertrophy, you will see a change in mechanics, cardiac mechanics. So you can see some of this change, and whether more aggressive changes in lifestyle measurements or even institution of therapies at that stage would be important questions that needs to be asked. And there is a lot of work that needs to be done in the future. But what can we do using machine learning? Well, all of these technologies can be used for extracting information automatically from the echocardiograms and populating it for creating a precise phenotypic assessment with high efficiency in a short period of time. Many of these tools currently are being translated. In fact, we don't need to know coding or anything else. Even sonographers with a touch of the button would now be able to get an automated measurements and create efficiently in the workflow. We just need to organize ourselves and make this happen so that we can ask all of these interesting questions in our clinical practice. And can we take into consideration all the beautiful work about the flow motion and the function integrated together? Yes. So all these different parameters that can be measured using cardiac ultrasound finally need to be pushed through the lens of artificial intelligence to identify phenotypes of diseases, phenotypes of heart failure. And in fact, this will allow us to create a new taxonomy of how we understand subclinical diseases, because there's an extreme amount of heterogeneity. Heart failure with preserved ejection fraction, heart failure with reduced ejection fraction is not one bucket. There are so many different small buckets and small different types of disease representation. And this individualized representation is extremely critical to define and is the single reason heart failure clinical trials fail, because you do not identify subsets of patients that will respond best to a therapeutic intervention. And since we do not do that, and we just do a bucket randomized trial for the heart failure trials, and that's one of the reasons why heart failure preserved ejection fraction has escaped, and we have not been able to develop therapeutic intervention for a majority of the patients in the community. So this paradigm needs to change, and we need to use the lenses of AI and phenotypic approaches where you can have high density information be converted into individualized patient representation for an early identification and intervention assessment. And we have some initial success in the stories. Heart failure can be identified, can be phenotyped, can be repressed in form of network diagrams where patients clusters at a higher risk of future event can be identified. Patients coming into the hospital at the point of contact who are likely to have higher events in the hospital, longer length of stay, we can identify all of that. So organizing our efforts as we move towards quality and outcomes of how we recognize proportions of patients who do not do well, and using the lens of artificial intelligence and big data analytics, I think is a great opportunity for us to define the future care of individualized interventions. And not only that, I think this is a great opportunity for us to grow new generation of leaders who are going to be able to thrive and evolve and continue to offer us new insight. It's been very exciting to see that despite my moving from Mount Sinai to New Jersey to West Virginia, we have continued to enrich and excite new investigators. So we have had 11 times we have been represented as Young Investigator Award finalist and American Society of Echo, and 3 or 4 times we have won them. And very recently, of course, we have not only won them, but we have also created many teams of champions who are not only working individually either at the level of the operations, clinical operations, but also engineers who are coming together and defining the future of healthcare. And this has also translated into some recent victory at NHLBI. We won the NHLBI 2020 Big Data Challenge for heart failure paradigms. And the story should continue. And I'm just thrilled the opportunity to invigorate, engage, and learn. The more you engage and learn from people, I think the better the science it becomes. And this is way we need to evolve. Finally, I think what we have to dream about is this. In New Brunswick, and we have an opportunity from physiology, disease mechanism to real implementation of the knowledge. How do we do the diagnostic surveillance and risk assessments in communities and home environments? What does electrocardiogram variables mean in terms of the phenotypes of heart diseases that we understand? Can we identify them in their confines of their home? Could we do the remote imaging? In fact, we are soon, in the next couple of months, going to test out robotic ultrasound. And in fact, we are ready to send ultrasound devices to homes, to patients, that they can actually image their own hearts. These are the concepts in the near future we're going to be testing in clinical trials. How can we recognize the disease and demise of the patients and the systems early on? Could there be a minority report type of environment in which we can predict, and the pre-crime environment? So early risk pattern recognition, disease forecasting, so that we can organize ourselves better. And of course, with the feedback, finally, everything is related to how we behave and behavioral changes. So there's a lot of work that needs to be done, but this opportunity is really right. And Rutgers really brings in a multidisciplinary and multicultural environment where some of this could be done. Despite all the challenges, I feel very optimistic. And the future, of course, is going to be, you need to create digital twins of patients and treat the twins and not the patient, not have the complication on the table, have the complication in the digital twin in a virtual environment, and do the computational modeling of the disease. Easy stuff can be done, but more complex stories should be first discovered. Problems should be discovered in a computational environment. And that's where the field is going. And there is a lot of opportunity to learn, not only here, but also elsewhere. And I'm really delighted that the work that we do here and abroad resonates. So when my journey started in India, every year I go back and try to give back something there. And sometimes I do clinical studies back in my hometown in Nagpur, where I have my hospital. And this has created this very vibrant community worldwide where people are interested in to learn from each other. And this is the environment that we need to create and to excite. And the story is all about teamwork. It's not about one person. It's about everyone else. And if this legacy can be created, that will really be resounding success for all of us. Thank you very much.
Wonderful. Thank you so much, Dr. Sengupta. It was a fantastic talk, and really an amazing trip through cardiac physiology. We've got, there was actually a lot of messages coming in. What an amazing lecture. So there's one question. Can you use echo techniques to demonstrate which drugs might be effective in treatment of HFpEF, preserved ejection fraction heart failure?
So I do not think we have enough evidence to say that we can identify a specific drug for treating HFpEF. Most of the work that at least has happened in HFpEF, we have escaped. I mean, none of the drugs have worked, except only recently we found that spironolactone and some of the GLP antagonists are working. But majority of the work in HFpEF is open. There is only a couple of phenotypes where HFpEF, when it camouflages as amyloid, it can be very specific to therapeutic intervention. So hidden in that whole battery of HFpEF are few phenotypes like amyloidosis. There is a specific therapy available. There is also some specific therapy available for hypertrophic cardiomyopathy. which can present as heart failure preserved ejection fraction as well in rare presentation. But most of the garden variety heart failure preserved ejection fraction, we use till now are using just a multi drug with using diuretics and some spironolactone, and just recently some anti-diabetic medications have been shown to be successful.
Great.
But there is a work that needs to be done.
Yeah,
there may
absolutely.
be some groups that may respond. Yes.
And then a question about how does CRT influence the helical contraction pattern? And it looks like the question wasn't completed, but
yes. So we did
CRT influencing the helical contraction pattern.
Yes. So we have shown, we have published and shown that actually the CRT, what it synchronizes is basically the two helices. So the endocardial and the epicardial function gets synchronized. In fact, the transmural, the block that you see in this when you do the activation map using electrical Partho and other techniques is a block between the endocardium to the epicardium. It's a very complex block. But this synchronization of the two helical band is been shown to be useful. Having said that, CRT is now applied based upon ECG criteria, so it has gone beyond the understanding is already applied. So it's very difficult to change the guidelines right now, but I think there's some more work required to be done to understand hyper responders and non-responders.
And can these models be used for CRT patient selection?
The model is as new as I'm speaking, right? So computational modeling is currently in its very nascency. So I mean, the clinical adoption somehow lags about a decade in anything. So all that I presented is still lacking. So we are just talking about computational modeling. Could it be done? Computational modeling is being adopted very fiercely in structural heart interventions right now. Could it be done for CRT? Yes, but it's not currently being utilized.
Okay, great. And obviously you've had an incredible amount of success in everything that you showed us. And I know how much passion you have for education. I'm wondering if you can talk a little bit about what you hope to do as chief, implementing some of your career success and improving the education of our residents and fellows.
I think, David, the basic message I have for at least anybody comes close to me is your clinical inquiry, right? So the sense of inquiry, asking question, right? All these questions start from the bedside, and you can reverse translate it or create your models and find out your answers, or do translational science as well. But when you stop thinking, the problem right now I have is people don't think. They're not thinking. We are not actively engaging. Even we do our engage with our patients, we sometimes actually stop from adequately thinking. And part of that is related to the workflow issues and how we are jammed up and we are lagging behind. But maybe using AI techniques, we need to create time to think. So first thing is to think. And then the second thing is to think out of the box. Never be settled with a theory if you're not able to see the full understanding, or if you think that you're lacking in somewhere. So that's the basic genesis, number two. Number three is not to feel shy to ask for help. To admit ignorance is fine. In fact, you may not have all the answers. So go outside your discipline, right? So the biggest triumphant moment happen is when you break the silos. So if you have an engineer, break the silo. Don't be asking the question in the same siloed environment. You may not get the right answer, or you may not get an answer that may be successful. So persistence and asking beyond the silos and out of box thinking is the critical need inquiry. And finally, if as a doctor, as medicines, we are not involved in asking why someone is not feeling good and what's the reason and how can I solve that? And any good physician does that. We need to inculcate that culture. I think somehow that culture has died out a little bit. We are settled with the mediocre performance of sometimes of clinical assessments, and that's not right. We need to pursue excellence and strive for the excellence and see what our passions are. And each one of us has got a spark. So that's what I try to bring. It's very basic and foundational. And we have created some innovation competitions, and we are challenging people to think differently. And it's okay. And another thing is, it's okay to have failures. It's fine. You're allowed to fail 10 times and have then 2 successes. That's fine. But not to attempt to do anything is again a problem. Complacency is a problem. So keep on being persistent, keep on moving, be excited, try to find your spark. I mean, I'm not saying, I mean, this is a very esteemed audience here. At least that's the culture we are trying to do. Every day in the morning lectures, morning reports, we try to create that environment.
Great, thank you, absolutely. Humility and curiosity, it's what's gonna help us be better doctors every day. Thank you very much, Dr. Sengupta. That was fantastic. We're at the top of the hour. Thank you again for a wonderful lecture, and we'll see you all next week and later today for the department faculty and staff meeting.
Thank you very much.